So first of all, Unicancer is the French Federation of Comprehensive Cancer Centers. We welcome you to this session on innovation for women at risk or affected with female cancer. This session will cover both innovation in preventive and predictive medicine, such as personalized screenings, as well as therapeutic innovations such as proton therapy and immunotherapy. This session will benefit from the presence of 8 internationally renowned speakers. So Eric Lambod from Institut Paul-Calmette, Alexandra Léry from Gustave Roussy, Jean-Louis Abran from Centre François Baclès, Suzette Delaloge from Gustave Roussy Institute, Dominique Stopal-Leonet from Institut Curie, Christine Rousset-Jablonski from Centre Léon Bérard, and Eric Leblanc from Oscar Lambré Center. I am Frédérique Penault-Llorca. I am working in a comprehensive cancer center in Clermont-Ferrand, France. And the subject of my talk is about genomic signatures and therapeutic de-escalation in breast cancer. 1 in 8 women will be diagnosed with breast cancer before the age of 85, so it's a major public health issue. For each new patient with breast cancer, we have to take account several parameters. So what is the context of discovery of this cancer? And what will be the treatment for the patient? So we have different options depending on the biology of the tumor. Chemotherapy, radiation therapy for the local regional treatment, and endocrine therapy. And for endocrine therapy for specific subtypes of cancer, we have to discuss the type of endocrine therapy, how long, 5 years, 7 years, 10 years. Then we have to take into account several elements of decision. What is the prognosis of the patient, so the risk of relapse, local and distant relapse, short or long-term relapse? What will be the chemosensitivity, so the prediction of response to chemotherapy? What is the potential hormonal sensitivity for the prediction of response to endocrine therapy over time? And what is the context? And this is very important. What is the general condition of the patient? What are the comorbidities? And what will be the personal choice? And we know that some patients, when they arrive with a diagnosis of breast cancer, they are not keen to be treated. So we have to have this discussion with them to decide the treatment options. In fact, we use several parameters to decide what will be the personalized treatment program for the patient. We use the classical parameters such as the TNM parameters, so the size of the tumor, the node involvement, the metastasis. And as it will be shown later, with the mass screening of breast cancer that is developed in our country, more than 2/3 of the patients will arrive with very small tumor. And with that, we have to take into account other parameters like the biology of the tumor. And for that, we have the pathological examination of the tumor. This is my job. I am a pathologist. So we look at tumor grade, histological subtypes, the biology of the tumor per se, so ER, PR status, estrogen, progesterone, and another important marker that is HER2 because we have targeted therapies for that. We look at proliferation of the tumor and other prognostic factors such as vascular invasion. The age of the patient will be also very important, and the surgical margins will be important for the radiation therapy. And in fact, we have several treatment options, and I will focus my talk on the part of that represent the majority of breast cancer, more than 70%, of patients who have tumors that express estrogen and progesterone receptor and that don't express HER2. And for these patients, we have a lack of precision concerning their prognosis and their chemosensitivity. So molecular signatures that are gene expression signatures have been developed in this group of patients with tumor expressing hormones to help us to decide for chemotherapy or not. And we know that in the past, many patients receive chemotherapy because of their tumor size or node involvement. And now we are in the process of treatment de-escalation. So we have, at least in France, four gene expression signatures: Oncotype DX, MammaPrint, EndoPredict, and Procinia. So we use our classical parameters, so microscopic evaluation and standard clinical parameters to define clinical risk between low risk and high risk. And we can use for those patients also gene expression signatures that will help us to define the risk. Are they low risk by gene expression signature or high risk? We conducted a study looking at what are the treatment decisions before, based on clinical data. So you can see here that majority of the patients were classified as eligible to a treatment combining chemotherapy plus endocrine treatment. And after the use of those molecular signatures, we observed a decrease of 60% in the chemotherapy decision, and 13% of increase in chemotherapy among patients who were initially prescribed with endocrine treatment. So this is really important to define a precise treatment that is suited to the biology of the tumor beyond the clinical parameters. So we had a 44% of change in the treatment decision. When we use those gene expression signatures, we can answer to different questions. For who do we need chemotherapy? So for aggressive disease. And how long will we prescribe endocrine treatment? Because it's not chemotherapy, but it's not like taking a mint pill. It's a treatment with a lot of side effects that could be very difficult to endorse for a patient for a long time. So at Unicancer, we have participated to major clinical trials like the MINDAC trial. UCBG was the first contributor in the world. And with this clinical trial, using MammaPrint signature, we showed that 46% of patients with high clinical risk and low molecular risk can avoid chemotherapy, and they represent 23% of the patients. We also participated to Responder trial. This trial, where we were also a large contributor worldwide, included patients with invaded lymph nodes, 1 to 3 positive lymph nodes. Usually those patients received chemotherapy. And this trial showed that for the postmenopausal patient with a low-risk gene expression signature with the Oncotype DX signature, they didn't benefit from chemotherapy. So it was a major change for those patients. But we show also something very important is that for premenopausal patients, about 23% of the population, those patients still benefited from chemotherapy. We also participated to other trials and designed one trial from our UCBG Unicancer group at Unicancer Research Group, the ASTER trial, looking at the benefit of chemotherapy in high-risk gene expression signature. So this trial is very important for elderly women, women after 70 years. And another trial looking at hormone therapy duration, the LESS trial, for postmenopausal patients, The aim is to shorten endocrine treatment to 2 years instead of 5 or 7 with patients with ultra-low gene expression signature. So we use different molecular signature for that, and those trials are, Aster trial will be published this year, and LES trial will start this year. Then we also explored other strategy, a strategy of neoadjuvant treatment. So the tumor is not operated upfront. It's the NeoPAL trial using a gene expression signature to select neoadjuvant therapy with Prosigna's signature. And another trial looking at patients with a high clinical risk, the UNIRAD, that was published this year, to intensify endocrine treatment in case of an high-risk gene expression signature with the EndoPredict signature. So we used all those signatures with the aim of having a more precise solution to offer to our patients in our research group from Unicancer in the UCBG breast cancer group. And using that and being really active members of the different trials, international trials, I think that we can say that for breast cancer, expressing hormone receptors and not expressing HER2, therapeutic de-escalation is a reality, as well as tailored, personalized strategy in breast cancer. And with that, I thank you very much for your attention. So now I'm introducing the next speaker, Professor Eric Lambody.
Good afternoon, everybody. I'm Eric Lambody. I'm an oncologic surgeon in Public Health Institute, Comprehensive Cancer Center from Unicancer in Marseille, France. And thank you for this opportunity to present the role of enhanced recovery after surgery and rehabilitation in the management of advanced stages of ovarian cancer. These programs are multimodal approaches of perioperative patients' clinical pathway designed to improve surgical but also oncological outcomes. Next slide, please. This patient-centered management refers to a specific organization in which the patient is informed and plays a involving surgeons, anesthesiologists, nurses, dietitians, physiotherapists, but also medical oncologists, geriatricians, and more recently fitness coaches include preoperative counsel, optimization of nutrition, standardized analgesic and anesthetic regimens, the use of minimal invasive surgery each time feasible, limiting drains and catheter placements, and early mobilization after surgery. Next slide, please. This.
Oh, sorry.
No
I have to go back. Okay.
Perfect. This patient-centered management refers to sorry, I missed my slide too. As illustrated on this slide, rehabilitation and ERAS must be integrated during the patient's clinical pathway from the diagnosis to the surgery during neoadjuvant chemotherapy, for example, to improve nutritional, physical, and psychological status, and to limit post-operative morbidity, and also to improve the return to intended oncological treatment, which may constitute in the future a quality indicator of our oncological clinical pathways. Next. This ambitious and cost-effective strategy needs to close collaboration between health professionals involved in these clinical pathways to recover patients' autonomy with a shorter hospital stay as a consequence of less post-operative morbidity. For oncological indications like ovarian cancer, these programs may have an impact on oncological outcomes, improving return to intended oncological treatment, RIOT, and limiting morphine consumptions. Next. But clinical trials are lacking. It is the reason why we have designed the training trial promoted by my institution, Public Health Institute, but with the financial support of the French National Cancer Institute and the participation of 6 comprehensive cancer centers from Unicancer. Training is a phase 3 randomized control trial with the main objective to determine if a prehabilitation program during neoadjuvant chemotherapy for patients treated for an advanced ovarian cancer will limit physical alteration between the diagnosis and a major abdominal pelvic surgery. 2 groups will be defined, a control group without prehabilitation program and an experimental group with a connected prehabilitation program. Secondary objective will include the analysis of morbidity, quality of life and oncological outcomes between both groups. Training will open this year. Thank you very much for your attention. Next.
Thank you very much. So now I'm giving the control to Alexandra.
So, hello, thank you very much. So I'm Alexandra Leary, I'm a medical oncologist at Gustave Roussy, and we're shifting gear today. Okay. There we go. So here we're going to talk about something quite different. Here I've chosen to focus on a fairly rare tumor that affects women. That's a female cancer, and here it's uterine cancer. And here I chose to present sort of a success story, okay? A lot of people have heard about immunotherapy to fight cancer, and there have been great successes in other tumor types like lung cancer, melanoma, bladder. But actually, to date, there had been few successes in female cancers. We're starting to get there in breast cancer, and here I decided to show an example in uterine cancer, where we're finally actually getting there, and I would argue it's one of the champions now. So a little bit of background on what is immunotherapy and how come it works. So we know here, if you see a cancer cell, it's in green, and the little red cells are immune cells, is that our immune system can attack foreign organisms like bacteria or viruses and can eliminate them. And now we've been now for a few years known that these immune cells can also attack cancer cells. Okay, and so there's been a revolution in cancer treatment, which is basically to give drugs that boost the patient's immune system to make it even better at attacking cancer cells. Okay, so which cancers respond best to not chemotherapy, to immunotherapy? Well, essentially, your immune system is going to recognize something the more different it is from self. That's why viruses, which aren't self, are recognized by the immune system. So to some degree, the more mutant a tumor cell is, the more different it is from a normal cell, the more likely it will be recognized by the immune system, okay? Here I've chosen to illustrate with X-Men, who I'm sure most of you know, which are mutant human species, and obviously they're quite different from most of the people walking down the street. Now that's all fine in X-Men, but actually in cancer, what makes a cancer cell more mutant, more different from a normal healthy cell from which it is essentially derived? Well, one way to make your cancer cell very mutant is to subject it to a lot of extrinsic damage, and that's what we've done with sun and with cigarettes, and these cause cancers like melanoma and lung cancer, okay? And all of this extrinsic stress will basically cause cancers that are very mutant, and that's why these were the first 2 cancers that responded to immunotherapy. They're so different from normal cells that your immune cells picks up on that, then you boost with immunotherapy, and these cancers respond very well, okay? And these are because they're very mutant. So that's all good and well, but how about our female cancers? Do we have certain women's cancers that are highly mutant and thus would be a good candidate to immune therapy, okay? And again, to some degree, when you look at a tumor, the uglier it is, the better in terms of responding to immune therapy. The more different it is from a normal cell, the better. Okay, and so what can turn, and here again I'm back to my X-Men, Jennifer Lawrence and her Mystique X-Men, well, it can be either extrinsic damage, and I've given you those examples, or actually it could be an extrinsic defect, okay, something that does that the tumor doesn't repair damage well, okay, and that's where it becomes relevant to some women with uterine cancers. Our cells are continuously replicating and making mistakes, but that's fine because we have all these systems within our cells that repair mistakes very, very well. And here I'm going to give you one example. It's one of these repair mechanisms called the mismatch repair system. That basically means if you get a point mutation, and here's a little error, black nucleotide here, well, it's recognized, removed, replaced, and you've got a perfectly normal cell. Now, what happens in certain kinds of uterine cancers and other types of cancer, actually, but uterine cancers are the most frequently associated with this defect, is that their system of repair, here it's their system of MMR repair, does not work. So they get a point mutation, an error. They don't see it, they don't repair it, and here you have a cancer that's very different from a normal cell, and this is what we call a hypermutated uterine tumor. So cancer of the uterus that's hypermutated, all the cancer cells look very different from a normal cell. So do these hypermutated, which we also call MSI, uterine cancers respond to immunotherapy? And the answer is yes. If you look at these hypermutated cancers of the uterus under the microscope, they're full of immune cells, so that if you boost them with an immunotherapy, they actually respond. And we have half of patients that have this type of uterine cancer. You give them an immune therapy every 2 weeks, 3 weeks, 4 weeks, 6 weeks, depending on the immunotherapy. Over half of them will have shrinkage of their tumor, and some of them the tumor disappears completely. The important thing is it's quite easy to identify women with this kind of cancer because we have an easy test, okay? And this is important because it concerns a quarter of women with uterine cancer. They will have these hypermutated MSI cancers, and these respond exceedingly well to immune checkpoint, immune therapies. Why has this revolutionized what we can do for our patients? Well, the standard of care in uterine cancer is depressing. We have first-line chemotherapy, and that's it, nothing else, okay? And so until now, women who relapsed after first-line chemo, there was an unmet medical need. We had nothing to offer these patients. Well, now we know that if they have these hypermutated MSI uterine tumors, we can give them immunotherapy. They've been approved by the EMA, the FDA, and that's really changed things. And as I said, we've treated most of these studies that led to the demonstration of immune therapy and these rare kinds of uterine cancers were conducted in France. We were among the best recruiters, and some of these women have complete disappearance of their disease. You can stop the immune therapy, and I'm seeing some 2-3 years after stopping the immune therapy, and they still have no visible disease. And this is raising the intriguing concept that maybe we might be curing a subset of these patients. So in conclusion, I want to just highlight a French trial. It's going to be led internationally, but it's initiated by French academic groups. And here's to say that's great. So immunotherapy works well after chemo. But how about in first line instead of chemotherapy? And here we have the Dominica Trial, which is going to take anyone with these hypermutated uterine cancers that's not eligible to local therapy, and they'll be randomized to standard of care, which is, as I told you, chemotherapy or an immunotherapy. And what's particularly interesting for our patients in this study is if they were randomized standard of care with chemo and they don't do so well here, they can actually cross over. Okay? So I think hypermutated MSI and uterine cancers are the new champion of immunotherapy. Okay, you can identify them, and they have among the best response to immune checkpoints. Okay, and this to me is the first demonstration of an unprecedented benefit for this novel approach against female cancers. And French sites participated very largely in the trials, making this proof of concept. We can identify them easily, And while we have it today for patients progressing after chemo, what we really want to do next, and here the French investigators have a major role, is can we even bring this immunotherapy to the first line to get rid of chemotherapy altogether for these women. And so that's all I had to say. An anecdote, but I think it's a positive anecdote, and French investigators contributed. So that's what I want to say today. Thank you very much.
Thank you very much, Alexandra. So I'm asking for control now.
I've given it back.
Thank you. Thanks a lot. So now I'm giving the end to the next speaker. If it's working. Okay. Okay, so sorry, I moved too far.
Yes.
So Jean-Louis, the floor is yours.
Thank you very much for inviting me, and thanks to the organizing committee, Unicancer and Healthcare, of course, to ask me to present some data as far as proton therapy. It's always a pleasure to talk of proton therapy. I've been involved in this field virtually since the beginning of my career, when I was at the time in the very first center in the worldwide, which was in Boston. And today I'm talking on behalf of the University of Normandy in Caen and of the François Baclès Comprehensive Cancer Center, again in Caen, where I've been developing one of the 3 existing proton therapy centers in France. I've also been involved in the development of the first one in Paris. So it's a pleasure to provide you with some insights of what proton therapy is and what could be the indications as far as breast cancer is concerned. It's only a preliminary experience, of course, but I think this is interesting. Next slide, please. Good. Next slide. Well, okay. So as you know, radiation oncology has enjoyed considerable developments in the very early time of 96, when it was experimented for the first time, both in France and US. And for example, we have based our technology on very primitive approaches in the past, like just anatomical landmarks in the patient, and later on 2-dimensional imaging. And then in the 90s, there was a considerable improvement with the development of 3D radiation oncology. And since the 2000s, what is amazing is the introduction of the intensity modulation of the beam, which again has revolutionized radiation oncology, which is called IMRT. And the most advanced technologies based on robotic approaches as well are called, could you put the entry, please? I don't have control, unfortunately. So yes, so the most advanced technology are called tomotherapy and cyberknife. So we probably heard of it, and now this represents something like 80% of our indications. But what has been just showing up on the right-hand side is that we have also more recently developed programs based on heavy charge particles under the barbaric name of hadron therapy, named from the physics counterpart. And in this context, proton therapy is probably the most developed at the moment, and is really a new revolution in the field of radiation oncology. On the right-hand side, you can see one of these novel treatment rooms based on proton therapies. This is, by the way, the treatment room that we are currently driving in Caen. And as I mentioned to you, there are 2 other centers in France. Next slide, please. So just to remind you very basically what is the difference between the photon therapy, the conventional photon therapy based on the conventional photons that are treating the majority of our patients, and proton therapy. On this slide, you have a very straightforward explanation showing that photons don't stop when they are going through the body, through the biological tissues, unlike particles, and especially protons that can stop at some point. And for example, when you consider a tumor located in depth, which is the red area on my diagram on the left-hand side, definitely it's clear, looking to this diagram, that the dose which is delivered upstream of the target volume is lower based on protons compared with photons, and this is somewhat clear. But what is more evident, even more, is that the dose which is delivered downstream of the target volume of the tumor is definitely totally different. It's virtually zero considering protons, so you have this sharp fall-off of the dose beyond the target, unlike photons that go through and through and deliver some unnecessary dose to the entire path of the radiation. And so one of the typical difference can be evidence on the right-hand side of my slide, comparing a proton beam and a photon beam. The photon beam, the X-ray beam on the left for an orbital tumor, evidences that there is a substantial dose that is delivered to the anterior part of the brain, for example, and even to the contralateral eye, unlike the proton radiation that stop abruptly beyond the orbit and spares totally the rest of the CNS and the fellow eye. Next slide, please. And so in this context, proton therapy has been developed in selected indications. As I mentioned to you, it's only a minority of patients nowadays, even in developed countries that can benefit from protons. And I can roughly say that there are three major indications at the moment. On the left-hand side of my slide, it's the ocular tumors, and it has been really a major advance in the management of ocular tumors to consider protons as a conservative treatment, and mainly in the ocular melanomas. On the middle is this funny type of tumor called skull-base sarcomas, a variety of sarcomas that are highly radioresistant and develop very close to anatomical critical structures like the spinal cord or the brain stem. So they are developing in the skull base, spinal and paraspinal area. And the last one, but not the least one, on the right-hand side, concerns the pediatric malignancies, in which the issue is not to escalate the dose and provide more dose in order to improve the local control of our treatment, radiation treatment, but mainly to spare the normal structures that are tissues in development and very sensitive to radiation. And protons do an excellent job. Could you push to entry, please? Okay, thank you very much. And so just to illustrate these three situations, on the left, a patient treated for an ocular tumor at the Paris Orsay Center that I had been ruling for many years, by the way. So a very accurate treatment with submillimetric positioning. On the center, you can see the dose distribution on this color wash representation of a sarcoma, of the skull-base sarcoma, in which there is a tight conformation of the red area, which is the high dose region, to the tumor, while sparing some structures very delicate, very tricky to spare in the middle. This is the spinal cord and the brain stem. And what is also remarkable is that the mid and low doses, which are so abundant as far as X-rays, are virtually totally absent as far as protons are concerned. On the right-hand side, again, a common indication in pediatric tumors, which are the medulloblastoma, a tricky type of radiation that aims to cover the entire brain and spinal canal. On the left is a patient treated using protons. Since nowadays we are treating medulloblastoma in some centers using protons, very tight conformation again to the brain and to the spine. To the middle is the elegant photon treatment, but now nevertheless, as you can see, all the green area, which is located anteriorly to the body, is a part of the body receiving some unnecessary dose, and possibly with further complication, especially in a child. And the right part of this final intercomparison is the difference between protons and photons. And all what is covered with photons and not with protons is displayed in green. And so a vast area of the chest, of the abdomen, and of the pelvis is unnecessarily treated using protons. So definitely I'm an advocate for proton therapy. Next slide, please. So definitely, this take-home message is quite important. We are reducing toxicity by dealing with protons. As far as breast cancer, so this is only very preliminary, but I would like to mention that sparing the normal tissue is not a trivial issue. We are mentioning here 2 slides indicating that following breast cancer, there can be some unnecessary toxicity due to radiation. On the left is a paper which has been famous by Dr. Darby, showing that there is a definite increase in the risk of coronary events and of cardiac toxicity for each gray, which is administered unnecessarily to a patient. And this makes, of course, a big concern as far as long-term side effects following breast irradiation in terms of cardiac events like coronary artery disease, mainly. We also know some other forms of toxicity like pericarditis, etc. And on the right, again, some other forms of toxic events following radiation of the breast, especially pulmonary events in terms of pulmonary fibrosis and also long-term secondary pulmonary cancer that goes with other forms of toxicity concerning a bit more rarely the esophageal tract, etc. So next slide. So toxicity is a critical issue as far as breast cancer is concerned, and we also have to be very careful of this. We add toxicity to the existing toxicity of chemotherapy, and dealing with the most innovating approaches in radiation oncology is not something trivial, is not something irrelevant, and I think this is very important. Next slide. Okay, I would like to illustrate what we are doing at the moment dealing with the protons in our center, which is to examine case by case patients that could potentially benefit from proton therapy or can actually benefit from proton therapy. This is the story of a lady treated for the past year, a very young lady, 33 years of age. She had a past familial history of multiple familial cancers, so definitely a patient at risk. At presentation, she had an advanced disease, a big mass which is visible on the MI on the right-hand side, palpable nodes that are also visible on my actual slide, view. Pathology was consistent with the grade 3 ductal carcinoma, and molecular biology evidence that she had a Lee-Fraumeni syndrome, which is characterized by deficient TP53. You know that gene is very important in terms of preserving the genome from alterations. The staging concluded that this was T3, triple negative, and the patient benefited from a very severe treatment, so to speak, but necessary treatment, combining chemotherapy, then mastectomy, since there was no superb response to chemo, and then radiation. And when the radiation came, we had the challenge to keep away as much as possible from toxic events, especially from secondary cancers that are not uncommon in this type of situation. And we elected for protons, and we are lucky enough to have a proton therapy center. This patient is doing perfectly well with 1 year follow-up. And to show you that we are definitely right by electing to treat her with protons, I'm showing you those intercomparison between photons and protons that we performed in this lady. On the left-hand side, you have the photon treatment, the X-ray treatment, and on the right-hand side, you have the proton treatment. And this color wash distribution shows that evidently the patient is well treated as far as her chest wall and internal mammary node by choosing advanced photon technology versus proton therapy. But what is quite different is the mid and low doses that are spread out all over the chest in this lady. And this was, believe me, an advanced photon technology called arc therapy, a form of intensity modulation. And evidently, the majority of the lungs, of the heart also are receiving some dose which is absolutely unnecessary for cure of the patient, versus protons, in which we have a superb sparing of lungs and cardiac structures. Next, well, so the protons win in this sort of situations. Next slide, please. And so, in conclusion, there is pros and cons. In my opinion, the pros are largely superior to the cons. Protons have proven highly successful in the selected cancer indication, as I mentioned before, the ocular tumor, the intracranial conditions, the spinal tumors, and the pediatric oncology, where it's now routinely applied in a number of centers worldwide. It gains more and more interest in more common cancer. Breast is not the only one. We are treating also now almost routinely esophageal cancers, pancreatic cancers can also benefit. There is a very large experience in prostate cancer. It's becoming so a must for preventing radiation-associated risk. And so this is, I think, my main take-home message. And so as far as breast cancer is considered, I think we should push our colleagues from the breast groups to consider for proton therapy patients that are young, who are young, we have genetic disorders and family history, and so some risk of further secondary malignancies. Those who have heart disease, of course. And so, again, what I didn't mention before is the anatomical abnormalities. We have some funny cases with some forms of malformation of the anterior chest wall called pectus recubatum, for example. And so we have been treating some of these ladies using protons. And in some situations, we can also advocate that proton can do a good job for re-irradiation. Re-irradiating a second course of irradiation in a patient with relapsing disease is not a piece of cake. And protons, after a careful examination, of course, of the entire medical history and previous irradiation, can benefit from the second course of proton therapy. We are doing it from time to time. The cons is, of course, the limited availability of the proton therapy center. Only 3 in France versus thousands of photon centers in our country. There is a waiting list which is generally protracted. There are potential contraindications, but few contraindications actually. And we also advocate, our colleagues advocate, that there is a lack of published clinical series, especially control trials like phase 3, and some potential reimbursement difficulties from the health insurance company and the public authorities. Next slide. So thank you very much. I also thank my colleagues from the Curie Institute I've been discussing with in the field of breast, and my colleagues at the François Wagner Cancer Center in Caen. And so I would be happy to reply your questions. Thank you very much.
Thank you very much, Jean-Louis. So we have received several questions. For the sake of time, I will only ask a few of them. So one question for you, Jean-Louis. Do protons decrease the risk of second cancer as well?
Well, this is one of the main goals of proton therapy, since as I mentioned to you, with this intercomparison for the same patient, the low and mid dose are far below when you are considering protons. It's very difficult to prove at the moment, since you need 15 to 20 years to evidence this sort of advantage. But this is, in theory, one of the main goal of proton therapy. It's not the only one, of course, but hopefully we will enjoy some decreased risk. There are still few, but there are, say, few publications showing that there is less risk. My colleagues in Boston, as I mentioned to you, I was part of the group 35 years ago. And the group in Boston, for example, published an intercomparison. It was not a randomized, but an historical intercomparison between photon therapy and proton therapy, showing that there were less risk of secondary cancer dealing with protons. And in the field of pediatric tumors, it was also shown in a recent paper that following the radiation of a retinoblastoma, a cancer that can occur in the eye of very young children, the risk of secondary cancer, which are in this case very bad osteosarcomas of the facial bones, was less dealing with protons compared with photons. So there are still some preliminary evidences of the advantage of protons. I have to say that if at some point, undoubtedly protons do a better job in terms of sparing the patients from secondary cancer, it would be really a tsunami in the field of radiation oncology, because it would mean that most of the radiation centers should have a proton unit, because if it's superior, our patients will request adamantly to have protons versus photons. But I may be a little bit enthusiastic in this field, but
I think it's a very good point. It will be very expensive and difficult to implement for the moment, but it's a very good point. I have a question.
Yeah, sorry. Okay. No, I would like just to mention that it's of course an issue. Proton treatment is considered something like 5-fold the price of a photon treatment. And my colleague in Curie, for example, wanted to have an academic trial conducted in breast cancer. And unfortunately, the reviewers of their project declined to enter in this very interesting study, because it was considered too expensive, and of course our national healthcare system would have to pay for the difference. And it's very unfortunate, because in the long run, we are saving lives and we are saving money for secondary cancer management, for example, dealing with protons. But
thank you. I have a question for Alexandra. What is the prevalence of MSI plus uterine cancer? So how many patients can benefit from them? And how many have Lynch syndrome? So familial predisposition for uterine cancer?
So 25 to 30% of women with uterine cancer have an MSI tumor. So it's almost a third of the patients, especially in the relapse setting. Amongst those, only about 5% will have Lynch. So the 90% will be somatic MSI and not linked to an inherited predisposition.
Okay, thank you. And I have another question about cervical cancer, because that's true that we are very disappointed about immunotherapy in female cancer. And we expected a lot from cervical cancer with the HPV infection. So do you have...
Yeah, so the first data that led to approval in the States was in the relapsed pretreated cervical cancer, where the response rate was only about 15%. So that led to approval in the States, but not in France. And we just had the results of the first line setting. So in cervical cancer, if you wait till they're heavily pretreated, these women are tired, they have fever, they have high platelets, low lymphocytes. Once they're heavily pretreated, they're not going to respond to immune therapy. So you need to put it earlier. So we finally have a first positive trial in the first line setting with chemo, and that improved overall survival and progression-free survival. So that's the first data, and I think we need to move it even earlier in combination with chemoradiotherapy and the curative setting, and those trials will be reading out within the next year.
Okay, thank you. We had also questions for Eric Lambodi. So, Eric, the women with ovarian cancer are usually old. I am in this category, more than 60, and they, I think, the approach of enhanced recovery after surgery and the prehabilitation is really very important. Who is the older woman you have in your trial, and what is your aim? Is it okay for them to accept this kind of approach, or you have seen also experienced limitation with women after 75 or
We all know that the age is not always a good indicator. That's why we need to work very closely with our colleagues, geriatricians, to evaluate our patients. And we do not have any limits concerning the age of the patient. It depends on the patient. So actually, the trial is not open. It's going to be open, I hope, in February. But due to the pandemic, it's not so easy to open. The difficulty in our trial is that the prehabilitation program will be connected. It means that all our patients involved in the arm prehabilitation will have connected watches and will use at home scale, body fat scale. So we have this difficulty, the difficulty of the connection of the digital part of our trial. But I hope it will work, and we will have a bias in our trial, certainly in the selection of our patient. But if we talk about the classic prehabilitation, it means nutritional, physical, and psychological support. We do not have any limit concerning the age of the patient.
Okay, thank you very much. So I just had one question on my presentation, so I'm going to ask it to myself. I have presented the data and all the development that we did at Unicancer for ER-positive, HER2-negative breast cancer with the molecular signatures. And the question was, do you have molecular signatures for the other type of breast cancer? So the answer will be very short. We don't use them right now in clinics and in clinical trials, especially for HER2. It's a kind of not a nightmare, but it's a kind of disappointment from us working for so many years on that. We didn't find really consistent predictive signature of response, but we are starting to have some data on that. And for triple-negative breast cancer, we know that we have some molecular subtypes that could indicate a better response to immunotherapy or PARP inhibitors, for instance. For the moment, it's not in routine practice. It's still on research. I think that now we have to move to the second part of our presentation. So the part on the innovation in preventive and predictive. So you can go.
MyPEBS, my personal breast screening. MyPEBS is a clinical research study testing if it is at least equivalent or even better for women to have personalized breast cancer screening based on their individual risk of developing a breast cancer instead of standard screening based on age. To answer this question, we are comparing two screening strategies: the current standard screening in our countries, where age is the only factor considered when inviting women to mammography screening, and a personalized screening strategy, in which how and how often to screen is decided on the basis of individual risk level, because not all women are the same. Everyone's risk of developing breast cancer is different, depending on genetic factors, density of breast tissue, family and health history. MyPEBS is currently recruiting volunteers. We'd like you to consider joining this study. If you decide to join the study, after getting all information and reading the information sheet, we will ask you to sign an informed consent form and to answer some questions on your medical history, family cancer history, and reproductive history. Then, you will be randomly assigned by a computer to one of the two study groups: the standard screening group or the personalized screening group. The chances of being in either group is 50-50, just like the flip of a coin. If you are assigned to the standard screening group, you will follow your screening schedule according to current breast screening practices in your country and area. If you are assigned to the personalized screening group, we will ask you to give a sample of your saliva to analyze your DNA. This analysis will take 2 to 3 months, and we will assess the density of your breast through your screening mammography. MyPEBS researchers will estimate your risk on the basis of the results of these tests, along with the questionnaires you completed at study entry, and will recommend you a specific screening protocol according to your risk level. If your risk is low, your next mammography will be in 4 years at the end of the study. If your risk is average, you will have 1 mammogram every 2 years, and also 1 ultrasound every 2 years if your breast tissue is dense. If your risk is high, you will have a mammogram every year, and also 1 ultrasound every year if your breast tissue is dense. If your risk is very high, you will have a mammogram every year and a magnetic resonance imaging scan every year until you are 60. Your participation in the study will last 4 years. During this period, we will ask you to follow your screening protocol, to update your information once a year, so that we can check if your risk needs to be reassessed, and to give some feedback about any concern you may have and your point of view and thoughts on MyPEBS. You will be able to give us this feedback on your personal portal on MyPEBS web platform. By taking part, you would help to define the best way to screen for breast cancer and potentially improve screening guidelines for all women in the future.
Suzette, on t'entend pas.
Thank you so much. This is Suzette Delaloge speaking. I'm medical oncologist at Gustave Roussy Institute, and I'm also, as you bet, the coordinator of the MyPEBS study and project. MyPEBS is a EU-funded project that is currently going on. So we are turning right now to prevention and screening, early detection of cancer. This is a big area that is in huge development in many of Western countries, including France, of course. So regarding breast cancer, what's the issue? The current issue is that regarding breast cancer screening, we have great data from randomized trials and cohorts showing that there are some benefits from screening, which include 20% decrease in breast cancer specific mortality, lower stage at diagnosis, some chemotherapies avoided, some mastectomy avoided, etc. But there also are some side effects or risks that are associated with breast cancer screening the way we do it right now. And these risks are limited sensitivity, and there are some around 17% interval cancers, even in women who have a 2-yearly mammogram. Some false positive recalls, around 3% of women will get a biopsy for a benign lesion at each mammogram. And there are some overdiagnoses. These are women diagnosed with breast cancer for whom the cancer would not have progressed to anything harmful if not diagnosed. And it's estimated currently, unlike prostate cancer, for instance, that this overdiagnosis rate is around 10 to 15% of all cancer diagnosed, but it's much higher, around 30% for DCIS. And last but not least, not with Proton, but with the other techniques we use right now for screening, it's X-ray. So we have a very small, very small risk of radiation-induced cancer. So the risk-benefit ratio is clearly in favor of mammographic screening the way we do it right now, but there is a major need for improvement. So what we aim to is going for personalized prevention. So what we are at is more stratified prevention right now, but personalized prevention is clearly something that is going to develop and will be probably standard 20 years from now. Stratified prevention is already something very important, which means that we are able to identify different risk groups. Towards that, we have very good data. We have risk scores that have been developed over the past 20 years, and during the past 10 years, we could add SNP scores. These are scores that gather a number of polymorphisms that are in link with the breast cancer risk, either increase it a bit or decrease it a bit, and all together have a strong effect on the ability to predict breast cancer. So as you can see here, with the best available SNP score, which is a 313 SNP score that has been described by Cambridge, the discrimination is very good for ER-positive disease, which can predict women with very low risk of breast cancer, and some of them have a high risk, whereas it's also discriminant for ER-negative, but that to a lesser extent due to the lesser prevalence of ER-negative disease, of course. So this is the basis of MyPEPS, which is a randomized study that compares personal risk stratified screening versus standard screening. So it's an international study. Sorry about the strange appearance of that slide. So it's a global project that has been funded by the European Commission, and it is ongoing. We will not look at all details, just to say that very important, not only it compares the efficacy of two different methods of screening, risk-based versus standard, but also it evaluates the social, ethical, psychological effects of having one's risk assessed, which is a very important issue. It assesses the economical evaluation of a potential risk-based screening for the future, and there is a lot about communication, etc. So this is the study scheme for MyPEPS. MyPEPS is now open in 6 countries, including Spain, UK, Belgium, France, Italy, and Israel. MyPEPS will accrue women from 40 to 70 years old, women who never got breast cancer and do not have a high-risk situation already identified. We aim to accrue 85,000 women in these 6 countries. And those eligible women are randomized between the arm 1, which is standard screening for 4 years. So women will continue with the standard screening they were already on before entering the study, or risk-based screening, which is a stratified arm, including the assessment of the PRS, which is inserted in a risk score that takes into account family history of biopsy, age, etc., mammographic density, and with that we assess a risk score that will allocate the woman, as you have seen in the cartoon, to a risk category, which is either low, average, high, or very high. And the screening program will be adapted according to the different categories. The primary endpoint of this study is the incidence of stage 2 or higher breast cancer in each group at 4 years. So we already have accrued 25,000 women in our 6 countries. The trial is currently ongoing, but it goes well, and these are good news. So we should be able to provide you with the major answers in some years from now. So the primary objective is to show that this stratified screening is non-inferior in terms of incidence of breast cancer of stage 2 and higher at 4 years. And the first secondary objective is to, if the non-inferiority is shown, is to show a superiority of the risk-based screening arm. And we clearly hope that it should be superior. So we have 6 countries, and Spain has entered recently and opened recently to accrual. Here we go. So all countries are active. This is the screening strategy that is currently proposed in the stratified arm. So it depends on the predicted invasive breast cancer risk at 5 years. If it's below 1%, the next mammogram is going to be 4 years. If it's between 1 and 1.66, then it's a 2-yearly mammogram. And beyond 1.67% invasive breast cancer risk at 5 years, we are on a yearly mammogram and eventually an MRI if the risk is very, very high, equivalent to BRCA carriers, for instance. And to that, we add an ultrasound for all women who have dense breasts. So MyPeps should be deeply changing the long-term breast cancer screening. The planned outcomes, as we have mentioned, is a strong evidence that has been asked by the European Commission to this trial to sustain the implementation of risk-based screening. And indeed, there are only 2 randomized trials assessing this very important question in the world. One is MyPeps in Europe, and one is the Western trial in the US. And so this will be the basis for the future European Commission, European Union recommendations. But we also will be able to assess the efficacy and risk benefits for an individual. We will be able to identify target populations of certain types and rhythms of screening, the cost, the psychosocial impact. We will have tools that could and should be ready for implementation in a large scale, and we should have the different stakeholders prepared in terms of communication, etc. But beyond that, of course, MyPeps is also a very huge database, and it's also a base for a biobank and for images, of course. So we should come out with new risk models, new risk genes, new risk SNPs, new images, and identification of images towards refining risk assessment, etc., new economical models. So it's clearly something that will go much beyond the results of a clinical trial. So this is really a very large enterprise with 27 partners all over Europe and Israel. I thank you very much.
So, good morning, everybody. So, ladies and gentlemen, and dear colleagues, I'm going to try to scan a very wide topic in a few minutes, and I apologize in advance for being elliptical. Yeah, and sorry. Okay. So the last 30 years have built a very large landscape of breast cancer genetic factors ranging from Mendelian genes to susceptibility factors. And on this diagram, genetic factors are reported in ordinate here according to their relative risk of breast cancer, and in abscissa according to the frequency of the carriers in the Caucasian population. And you can see that BRCA1 and BRCA2 carriers frequency is high and Gazer close to 0.3%. That means one individual in 300, which is very high. PALB2, CHEK2, ATM genes are associated with moderate risk. More recently, single nucleotide polymorphism, or SNPs, have been identified through genome-wide association study, and these susceptibility factors are combined in a polygenic risk score, PRS, and PRS is at the heart of the important clinical trial, MyPeps. The prevalence of BRCA1 and 2 carriers among women affected with breast cancer is about 2.5%, and if you had PALB2, ATM, and CHEK2, is about 5%. The estimation of cancer risk is crucial for defining the management of at-risk women. And in this prospective European study, the lifetime risk of breast cancer in women carrying a BRCA1 pathogenic variant is estimated to 72%. And figures are similar for BRCA2. And women affected with the first breast cancer have a high risk of a contralateral cancer, and the annual risk is 2% for BRCA1 and 1.5% for BRCA2. And of course, besides to breast cancer, there is also a high risk of ovarian cancer, especially for BRCA1. What are the main features of the management of BRCA1 or BRCA2 carrier. Recommendations are similar worldwide. Annual breast screening by MRI, mammo, and ultrasonography beginning at age 30 is recommended. Prophylactic mastectomy has to be discussed. Mastectomy uptake differs by country, high in the US, the UK, and the Netherlands, but lower in Spain, France, and Italy, for example. Prophylactic salpingo-oophorectomy, that will be presented in the next talk, is strongly and worldwide recommended at age 40 or later, according to the gene involved. Regarding other genes such as ATM, CHEK2, or BARD1, or FALB2, which are, I told you, moderate risk, management guidelines have not yet been established and differ according to the family story, but I would have also to country. And the management, the management of women will be improved when we will be able to estimate individual risk by taking into account modifying risk factors. There are clearly factors modifying breast cancer risk. This is illustrated by family history, by the risk of women born before the 40s or born later. That means that lifestyle and environment risk factors are associated, and there are also genetic factors. And you have also here the PRS that I mentioned for my pets, and you can see here for each Mendelian genes the distribution of breast cancer risk at 5 years according to individual PRS. And you can see here in blue, for example, the distribution of risk for different women. All are carrier of a BRCA2 pathogenic variant, but there is a large distribution of risk according to the PRS. And it is expected that next generation of tests will integrate to multiple gene panels such modifying factors. Another challenge awaits us when sequencing BRCA1 and BRCA2 and all genes, besides pathogenic and benign variants. There are variants of unknown significance because we do not know their biological and thus their clinical significance. And views are the nightmare of geneticists, and therefore also of the tested women. And in the French oncogenetic database, Freud, more than 50% here of BRCA1 variants are used, and figures are similar in other national or international databases. And international collaborations for classification of views are strongly needed. They are underway through Enigma and the BRCA Challenge of the Global Alliance for Genomics and NF. The last part of my talk. The BRCA2 and BRCA1 and BRCA2 genes have been identified more than 25 years ago. But it is only 3 years after their identification that we understood that the BRCA protein were involved in the repair of DNA double-strand breaks by homologous recombination. 10 years later, in 2005, in vitro analyses have shown that the usefulness of stopping the base excision repair pathway in BRCA invalidated cells by using PARP inhibitors. And 9 years later, in 2014, the first clinical trials of PARP inhibitors were a breakthrough in the treatment of women BRCA carriers and affected with ovarian cancer. And now PARP inhibitors are useful for a woman BRCA carrier and affected with an advanced breast cancer. in summary and as take-home messages, I would like to underline that BRCA1, BRCA2, and other breast cancer genes have opened up a new field in medical genetics. Hereditary breast ovarian cancer multi-gene panels are one of the most common genetic tests worldwide. Two main challenges are remaining: the integration of modifying factors in tests and the classification of variants of unknown significance. And BRCA testing is now standard for women affected with ovarian or advanced breast cancer. Women need to have quality care. They need to be informed and supported because they no longer have choice of being tested or not tested. I thank you very much.
Christine, your presentation.
Good morning, everybody, and I'm very honored to represent France for this presentation, and I will talk about fertility preservation in women with breast cancer. I am working in Centre Léon Bérard in Lyon. So why should fertility preservation be discussed? Because 5% of breast cancer occur in women younger than 40 years old, and because age at pregnancy desire has become later and later, with a mean age at first pregnancy of 29 years. The period between 30 and 40 years old corresponds to a decline of ovarian reserve, which is associated with a fertility decline. And mainly in women after 30 and mainly after 35 years old, the fecundability, which is the probability of getting pregnant for each month of attempt, falls down. Women with breast cancer will face two factors that can decrease their fertility. First, the toxicity on the ovarian reserve of the chemotherapy. And second, the time that they will have to wait before getting pregnant, and especially in case of hormone therapy that will last 5, sometimes 10 years. And during this time, their ovarian reserve will still decrease naturally. We also should discuss fertility preservation because we now know that pregnancy after breast cancer is safe. Strong data conclude that pregnancy itself after breast cancer does not appear to increase the risk of recurrence, and disease-free survival and overall survival even were found to be better among women who have a full-term pregnancy after breast cancer, after adjustment on prognosis factor, and thus avoiding the healthy mother effect. 2020 ESMO guidelines conclude that pregnancy after breast cancer should not be discouraged. But should we intervene to preserve fertility in all women with breast cancer? Fertility preservation is in fact the prevention of a potential future infertility, and so as every prevention, it should be discussed in an individual benefit-risk balance. On one side, we have to take into account the future infertility risk of the woman and the efficiency of the methods that we can propose, and on the other side, the risks induced by these methods. Finally, the methods have to be feasible, and fertility preservation need to be included in the care pathway. We now have some international guidelines that can help us in the decision making, but at the end, this benefit-risk balance should always be assessed individually. So here are the different fertility preservation methods available in 2022. Generation agonists, whose efficiency is still discussed. The ovarian cortex cryopreservation, but which is not the first choice method for women with breast cancer, because this method can damage ovarian reserve more than the chemotherapy itself. And as in BRCA women, the ovarian tissue may not be replaced. Immature oocyte retrieval followed by in vitro maturation, but whose efficiency seems to be low, as only a few births were published until now. And finally, the ovarian stimulation followed by mature oocyte retrieval and oocyte or embryo cryopreservation is the preferred method because of its effectiveness and is considered by ASCO as an established fertility preservation method. But when looking at the benefit-risk balance, especially for ovarian stimulation and oocyte vitrification, one point to discuss is the expected efficiency of this method in terms of number of oocytes retrieved and in terms of probabilities of pregnancy. Some data show that women who use their oocytes after the breast cancer have living birth rate between 32 to 50%. But as the woman gets older, the number of oocytes to retrieve, to have good probability of live birth rate increase. And thus in women with a low ovarian reserve of age more than 38 years old, the probability of success and the relevance of this method should be discussed. On the other side, concerning safety data, there is still little safety data, but despite the hyperestrogenism induced by the stimulation, the retrospective and prospective observational data that we have show no increase in recurrence risk among women who do this ovarian stimulation in the context of breast cancer. Also, this data concern only diseases at limited stage now. One of the major challenges is to respect the optimal time before beginning the chemotherapy and to integrate fertility preservation in the care pathway to be able to achieve 1 to 2 cycles of stimulation without delaying the chemotherapy. Finally, the decision of fertility preservation should be multidisciplinary, integrating oncologists, gynecologists, and of course the patient herself in a shared medical decision. I thank you for your attention.
Thank you very much, Christine. And now the last talk by Eric Leblanc.
Well, dear ladies and gentlemen, dear colleagues, good afternoon, because I think it's afternoon right time in Dubai. I'm Eric Leblanc, I'm a surgeon working in the Department of Gynecology and Oncology at Oscar-Lambray. This topic is the last but not the least, and we'll focus in an important public health care issue, the prevention of ovarian cancer. I will fasten my presentation because we are short in time. Just to say that if this cancer is not the most frequent, it's by far the most lethal. And if ovarian cancer consists of around 15 different subtypes, the most frequent and dangerous is the high-grade serous carcinoma. And it is found in 15 to 18% of people, especially those carrying a mutation of BRCA genes, 1 or 2. And when these genes are mutated, the risk of breast ovarian carcinoma, especially ovarian carcinoma, is very high, up to 40% for BRCA1 between 35 to 70 years old. Less frequently, the genes from the Lynch syndrome may be responsible for ovarian cancer as well. Of importance is that the risk of ovarian cancer in mutated patients, BRCA mutated patients, increase exponentially with time, with roughly 10% risk at 50, 20% up to 60, and 40% up to 70 and above. That prevention is highly desirable. Next slide. So the first is the screening method, combining ultrasound and biological marker in different combinations, and unfortunately they were unable to prevent effectively ovarian cancer nor reduce the mortality, because ovarian cancer is a rare disease. 1 woman out of 70 will be affected by this disease, and with a quick evolution as soon as initiated. Combined contraceptive pill blocking ovulation has demonstrated efficacy at preventing the disease, but this treatment is not always tolerated nor indicated, especially in case of history of breast cancer. Finally, surgery seems to be the most efficient method. Tubal ligation used for contraceptive intent has already demonstrated it could prevent ovarian cancer, but especially endometrioid or clear cell, but not the high-grade serous carcinoma. And since the 80s, the bilateral risk-reducing salpingo-oophorectomy or adnexectomy is the most effective and worldwide standard of protection against ovarian cancer, especially in the population of BRCA-mutated ladies. But before, this prophylaxis is not without detrimental effect on the quality of life of this patient because of osteoporosis, hot flashes, impaired libido, and increase of coronary disease or neurologic disease that may impair the life expectancy. That's why 30% of these at-risk patients refuse or delay this operation, exposing themselves to this dreadful disease. Next one. In the 90s, pathologists using accurate methods of examination found an unexpected rate of abnormalities, especially located at the ovarian extremity of the fallopian tube here, which is called the fimbria. They demonstrated stepwise evolution of abnormalities towards an invasive cancer of high grade. So, although supposed to be at the origin of ovarian cancer, ovary was only a metastase of a tumor born into the distal part of the tube. Thus, a two-step prophylactic operation associating a salpingectomy, removing only the tube, and followed by a delayed oophorectomy sounds logical to prevent high-grade serous tumor while avoiding the adverse effects of castration in early women. And following this concept, we suggested in 2012 to perform a national study, PHRC, for these ladies with a mutation who refused to have the risk-reducing salpingo-oophorectomy. So we performed a radical fimbrectomy, which is the removal of the tube and the tiny part of the ovary attached to the tube, because some suggested the pathology rose at the stem at the junction between the two epithelia. And the results are now available and are currently under publication. 120 ladies, it's a pilot study, were submitted to this operation, and with 7-year median follow-up globally and 9-year for a specific follow-up, we never observed any ovarian or peritoneal high-grade serous carcinoma. And the surgical morbidity was equivalent to risk-reducing salpingo-oophorectomy. And for those who had a secondary oophorectomy, we never observed any abnormalities on this specimen. Thus, this policy of two-step prophylaxis seems valuable and in this high-risk population, and deserves to be tested on a larger cohort of high-risk ladies, as suggested in the international study called TUBA-WISP-2, who will give to the patient the choice between RRSO or risk-reducing salpingectomy with delayed oophorectomy. 3,000 ladies are expected to enter this trial, and it will be a very great opportunity for them, for those who refuse the risk-reducing salpingo-oophorectomy. But for the non-high-risk ladies now who are candidates for conservative surgery, hysterectomy with opportunistic salpingectomy, keeping the ovaries in place, had absolutely no adverse effect and participates as well at limiting this risk in the general population. I hope I kept my time.
Yes, thank you very much. So I have to apologize for the 4 last speakers because there is another session just after us and we will not have time to take any question. But if there are any questions, you can send them by emails and our colleagues will respond to them. I would like to say that this session, this second part on innovation and preventive and predictive medicine is opening wide hopes for the patients. I think it's really a very large part of innovation to be in this preventive medicine. So I think we have shown this afternoon the excellence of the French Unicancer group in terms of therapeutic innovation and in terms of prevention and predictive medicine. I would like to thank very much all the speakers and I would like to thank the audience for your attention.